So this is resistant and secondary hypertension. It's the next board review. Again, we're going to be using the audience response system. In the last 45 minutes, I haven't changed my financial relationships. So first case, 55-year-old man's referred to you for chronic resistant hypertension despite taking these 4 medications: lisinopril, chlorthalidone, amlodipine, and metoprolol. He's compliant with these medications. He drinks 3 to 4 alcoholic beverages per week. He does not take nonsteroidal anti-inflammatory drugs. He says that he doesn't add salt to his food at the table. He doesn't use the salt shaker. He snores, but he says he doesn't have headaches during the day. He does not fall asleep during the day. He doesn't have hypersomnolence. And his wife is not aware that he stops breathing in the middle of the night. His blood pressure is 160/90, and this is consistent with the readings he's getting at home. He's obese, and he has 1+ pitting edema. His creatinine is normal, his potassium is normal, his urinalysis is normal, his TSH is normal, his calcium is normal, and his PTH is normal. So which of the following is most correct? A, his alcohol intake is probably contributing to his resistant hypertension. B, the sodium intake is not contributing to his resistant hypertension because he doesn't use the salt shaker. C, if you were to do a sleep study, polysomnography, you would probably find sleep apnea. Or D, you should not bother doing a sleep study specifically because he does not have symptoms of sleep apnea, such as hypersomnolence or daytime headaches or things like that. Okay. So C, 84%, that is the correct answer. So this is a case of resistant hypertension, and as you probably know, resistant hypertension is defined as follows. It's blood pressure that remains above goal despite using at least 3 antihypertensive medications of different classes. One of the 3 medications should be a diuretic, and all of the 3 medications should be prescribed at optimal dose. What does that mean, optimal dose? It means that the dose of the drug that you're using is 50% or more of the maximum recommended antihypertensive dose. And as a consequence of this definition, if you've got a patient who's controlled but requires 4 or more medications to control their blood pressure, they are defined as having resistant hypertension as well. People who appear to you to have resistant hypertension are relatively common in the population. So if you look at all hypertensive, these are data from NHANES. If you look at all hypertensive patients, about 9% appear, based on those criteria, to have resistant hypertension. And about 13% of patients who are being treated with antihypertensive drugs have resistant hypertension. So apparent resistant hypertension is relatively common. And the reason I was using the word apparent is because if you think about the causes of resistant hypertension, one of the main causes is that it's not really resistant hypertension, but it's actually pseudo-resistant hypertension rather than true resistant hypertension. And pseudo-resistant hypertension is fairly common, as we'll discuss, and can be caused by either suboptimal therapy, such that the doses are actually not optimal doses, or they're not using a diuretic, that the meds are not optimal, so not using the right medications, or that the patient is not taking the medicines that you're prescribing them. Another cause of pseudo-resistant hypertension is white coat resistant hypertension. So just going into suboptimal therapy, this was a series of data from about 500,000 hypertensive patients followed in the southeastern United States over a 3-year period. And about 18% of this population appeared to have resistant hypertension based on their blood pressure and the fact that they were taking 3 drugs or more. Some were controlled on 4 medications, some were uncontrolled on 3 medications or more. But if then you looked at which drugs they were taking, whether they were on a diuretic and 2 other classes of medications, whether they were on optimal doses of those drugs, really those with quote-unquote true resistant hypertension, and actually this isn't quite true resistant hypertension because we don't know whether they're actually taking these therapy, we just know that they're prescribed these therapy, that about 8% of these 18%, so 18 down to 8, actually had true resistant hypertension. So seemingly a lot less common than thought. Then if you think about, okay, you got your patient on the right therapy, but they still have resistant hypertension. The question is, well, are they taking their meds? And you can ask them whether they're taking their meds. But this was a very interesting study from a couple of years ago in the Journal of Hypertension. It's been repeated by a group of investigators in England. And this was a study of 375 patients who referred to a hypertension clinic because of resistant hypertension. And for hypertension, I should say, and out of these 375, 108 appeared to have resistant hypertension. 76 were without secondary hypertension after a workup and were uncontrolled despite 4 or more medications. So these 76 patients who appeared to have resistant hypertension, not secondary hypertension, had their urine sent for liquid chromatography and mass spectrometry. And what was found was that half of these patients were not taking the medications as prescribed. About 53% were not fully adherent. A small percentage were taking more than half of their blood pressure meds, but up to 26% were taking fewer than a quarter of the medications that were prescribed, despite stating that they were taking these medications. So you have your patients who appear to have resistant hypertension. A good number of them may not be on the correct medications or at the correct doses. And then of those, a good number of them may not actually be taking their medications, and that's why they have resistant hypertension, not because they have resistant hypertension. So causes of resistant hypertension, one, it's not really resistant hypertension. That's a big category. We didn't even talk about white coat hypertension, but you can evaluate that by getting home blood pressure readings or ambulatory readings. Obviously, another cause is obesity. Poor diet is another cause. And then secondary hypertension, you could think about why poor diet and obesity are not considered causes of secondary hypertension, because they are secondary causes, but they're not classified that way. Other causes causes of secondary hypertension are listed here. Primary kidney disease, drugs such as NSAIDs, alcohol in excess or oral contraceptives. Sleep apnea is very common, primary aldosteronism, renovascular hypertension, hypothyroidism, and then the causes closer to the bottom are much less common. So I just want to go back to the case to go through the various response options that you had. So option A was alcohol is likely contributing, and here it says that he's drinking 3 to 4 alcoholic beverages per week. Obviously, people can lie about how much alcohol they're drinking, but let's just assume for the moment that this is true. This level of alcohol consumption shouldn't cause resistant hypertension. So this is a study of alcohol consumption and risk of hypertension in a large group of men. The results look fairly similar in women, but basically this is 30 or more grams per day, with 10 grams of being about 1 drink. So about 3 drinks or more in men per day on average is associated with an increase in blood pressure. In women, the curve is shifted a little bit to the left, so 2 drinks or more per day on average in women can contribute to hypertension. So he denies adding salt at the table. And so one option was that sodium is not contributing, and obviously this is false, because out of the 10 grams or 4,000 milligrams of sodium, or of about 200 millimoles of sodium that most of us are eating on a daily basis, only a very small percentage of this pie of sodium that we're consuming every day actually comes from added salt with cooking or from the salt shaker, whereas all of the salt that we're eating, which is a very high amount, is coming from food that we buy either at the store or at a restaurant. And the effects of sodium obviously are on blood pressure have been established in multiple trials. It's greater in hypertensives than in normotensives. So sodium certainly could be contributing to his blood pressure. And then the other options dealt with sleep apnea. So he denies hypersomnolence or headaches, and his wife is unaware of any apneic episodes. So it turns out that most obese patients who have hypertension have sleep apnea. About 50, and that's not even considering resistant hypertension, about 50 to 90% in various series. And the best predictors, out of the 4 best predictors of whether or not a patient has sleep apnea, obesity and hypertension are 2 out of the best 4 predictors. The other 2 are snoring, which the patient had and witnessed gasping, choking. And the questions such as hypersomnolence and headaches during the day, these are actually non-sensitive for diagnosis of sleep apnea. And I said 50 to 90% of all hypertensives. It becomes much greater if you're talking about a population of obese patients with resistant hypertension. These are two studies that found almost identical results. These are overweight or obese individuals with confirmed resistant hypertension, and in both studies, more than 80% of patients had sleep apnea. So the answer here is that polysomnography would most likely be positive for sleep apnea. All right, so this gentleman, you refer him for a sleep study, and this demonstrates an AHI, or apnea-hypopnea index, of 20 events per hour, which is consistent with moderate sleep apnea. He starts on CPAP and is seeing you 2 months later. He's using it nightly. He says he sleeps well. He feels more energetic. He still takes his same regimen. His exam is unchanged, and now his blood pressure is roughly the same as it was before. So what is most likely to result? Which of the following is most likely to result in better control of his hypertension? A, spironolactone, 25 a day, titrating up to 100 a day as needed. B, an exercise program of walking 20 minutes 3 times per week. C, send him back to the sleep clinic to adjust his CPAP because it's not working. D, send him to ENT for laser-assisted uvuloplasty. E, catheter-based renal denervation. Or F, creation of a central arteriovenous anastomosis. Okay. So, first of all, the effect of CPAP on blood pressure has been evaluated in a number of randomized trials. It's variable, the results in any given patient. A meta-analysis, which was published a few years ago, of 29 trials comparing CPAP with either no therapy or CPAP with a blood pressure medicine or an oral device, found that CPAP in patients with hypertension has a modest effect on the blood pressure. The average effect was about 2.6 millimeters of mercury. And compared with adding an antihypertensive therapy, actually had was worse with CPAP in patients with sleep apnea and hypertension. On the other hand, spironolactone has been found to be effective in patients with resistant hypertension. This was shown initially in a large study in the ASCOT trial, which wasn't specifically looking at resistant hypertension or at spironolactone, but was rather looking at a variety of antihypertensive medications to treat hypertension. But in this trial, there were guidelines as to what drugs should be used in what order. And there were a variety of drugs used as initial therapy, doxazosin as a third drug. But then if the patient needed a fourth drug to control their blood pressure, there were a variety of different drugs that could be used. And of these patients that needed a fourth drug, 1,400 of them received spironolactone. So these are observational data because spironolactone isn't being compared directly with another drug. But in those patients who needed a fourth drug and in whom spironolactone was added as that fourth drug, in this trial there was a substantial reduction in systolic blood pressure, 22 systolic and 9 millimeters diastolic, that should say DBP, sorry. These are observational data, but there are also several randomized trials of spironolactone in patients with resistant hypertension. I'm going to present one here. This is called the aspirin trial. This was 117 patients with resistant hypertension on an average of 4 medications, and they were randomly assigned to spironolactone at 25 milligrams a day for 8 weeks, or placebo for 8 weeks, and were followed with 24-hour ambulatory blood pressure. And what was found in this study was that 24-hour systolic blood pressure substantially decreased with the addition of spironolactone, 25 milligrams, and that diastolic blood pressure decreased to a smaller amount, but did decrease. Office systolic blood pressure also decreased substantially. And the other trial of spironolactone and resistant hypertension found similar findings. And what about, so spironolactone appears to be effective in patients with resistant hypertension, but renal denervation obviously is a very hot topic and has been the subject of a number of studies. This was a trial in Lancet in 2010. This was the Simplicity 2 trial, and there were 190 patients with resistant hypertension that received either just what they were usually doing or renal denervation, and followed for 6 months. And the patients who received renal denervation, as you can see, had a huge decrease in blood pressure. At 6 months, office systolic blood pressure decreased by 32 millimeters of mercury, and diastolic blood pressure by 12, and there was no change among the group of people who were just doing what they normally do and didn't receive the procedure. Just in the past few months, this trial was published in The Lancet. This is the Diener hypertension trial, or Diener HTN trial. And the objective here was to compare renal denervation with optimal medical therapy, as opposed to just doing nothing. And this was 106 patients with confirmed resistant hypertension, despite indapamide, like I said, a thiazide-like diuretic, amlodipine, and ramipril, or if they were allergic to an ACE inhibitor, irbesartan. So everybody got the same medications in this trial. And they were assigned to one of two groups. Either they got stepped antihypertensive therapy, and stepped antihypertensive therapy was the addition of spironolactone, followed by a beta blocker, followed by an alpha blocker, followed by a rilmenidine, and it was all in that order with the goal of having the home blood pressure be less than 135. So the additional medications were added as needed to get the home blood pressure less than 135/85. The other group got catheter-based renal denervation using the Simplicity catheter plus stepped antihypertensive therapy. It was an unblinded trial, so everybody knew who got renal denervation and who didn't, and the follow-up was 6 months. The endpoint was 24-hour ambulatory systolic blood pressure. And here are the results of the study. So if you look at the top graph, 24-hour systolic blood pressure at baseline and at 6 months, the blue line is renal denervation, the green line is no denervation. And as you can see, that the change in blood pressure with renal denervation was significantly greater than the change in blood pressure without renal denervation. Okay, and this was 16 versus 9, the change from baseline to 6 months. However, if you look at where they wind up at 6 months, they're roughly similar, lower with renal denervation, but roughly similar. And then if you look at the bottom graph, you can see that there was no difference in the number of antihypertensive medications that the two groups were getting. So the people with renal denervation were getting the same number of antihypertensive medications basically as those who were in the stepped group. The other thing is, if you look at the curves, the renal denervation group were coming in at a substantially higher baseline systolic blood pressure compared with the no denervation group, and there is this phenomenon of regression to the mean, which can sometimes be used to explain the results of these trials. So because the baseline blood pressure was higher in the renal denervation group, is it possible that there was that the change in blood pressure being greater in that group, although they wound up at roughly similar blood pressures, whether the change was because of a higher baseline blood pressure in that group with regression to the mean? Other concerns about this trial was that there was no sham procedure, and everybody knew who was getting their denervation, and we'll talk about Simplicity 3 next, which was a blinded trial. And people that were lost to follow-up were exclusively, all of the patients who were lost to follow-up were exclusively in the denervation group, and those patients didn't have any blood pressure data, so we don't know what happened to those patients. This was actually preceded in publication by the Simplicity Hypertension 3 trial, which was a similar trial of a larger trial, 535 patients with resistant hypertension, published last year. And what was interesting about this trial is that this was blinded. So patients either got a renal denervation or they got catheterized, but they didn't get radiofrequency ablation. So there was a sham procedure, and the patients didn't know which procedure they received. The follow-up was 6 months, and with denervation or sham, there was no benefit on clinic blood pressure, as you can see from the figure, and there was no benefit on 24-hour ambulatory blood pressure, and 1% of the patients in the study had serious adverse events. So at this point, it's really not clear whether renal denervation, and there are certainly concerns about this trial as well that have been raised, but at this point it's not clear whether renal denervation, what the role of that is going to be in the treatment of resistant hypertension. So the jury is still out on that, but in terms of what to do next in a patient with resistant hypertension, the spironolactone has been shown to work. Renal denervation, there are concerns and questions about this. Something very new, which was published this year in Lancet, is arteriovenous anastomosis. That's why I had the last option there. which nobody selected. So this trial was published in The Lancet earlier this year using this device, which you can see in the lower picture, called the ROX Control hypertension device. And this is a device which, and I'm not a vascular surgeon or interventionalist, but it is somehow using the iliac artery and the iliac vein placed in between these two vessels such that blood is shunted from the artery into the vein, creating this central AV anastomosis. And this was actually discovered incidentally when being used for patients with pulmonary hypertension, that it actually substantially lowered blood pressure. So this was a trial of 83 patients with resistant hypertension on 5 medications. They created the AV anastomosis in the iliac artery and iliac vein using this device, or the patients just got their normal therapy and followed for 6 months. And as you can see over on the left, nothing happened in the control group, but there were substantial drops in blood pressure in the patients who got this AV anastomosis, this new technique for treating resistant hypertension. However, there were a whole variety of adverse events. About 30% of the population who got the device had a venous stenosis. There was arterial deployment, so the device going into the artery in 7% of patients, iliac dissections in 2% of patients, and 2% of patients received DVT. And also, it was a 6-month trial, and long-term adverse effects, effects on cardiac output and hemodynamics were not assessed in this trial. So to control hypertension in most patients, going back to our first lecture, start with an ACE inhibitor, an ARB, or a long-acting calcium channel blocker. Step 2 would be the combination of these two drugs. Step 3 would be adding chlorothalidone or indapamide. And if they're still not controlled so that they have resistant hypertension, then the next step would be to, at this point, to add an aldosterone antagonist. So that's the right answer. So resistant hypertension and secondary hypertension are related, and so we're going to be switching gears a bit and talking about secondary hypertension. So if you're going to, one of the questions is, who do you evaluate for secondary hypertension? So if you have a patient who has true resistant hypertension, that would be somebody you would evaluate for common forms of secondary hypertension, sleep apnea, for example, primary aldosteronism. You would also evaluate for common forms of secondary hypertension, or even for uncommon forms of secondary hypertension, if you had a patient that was sort of telling you to evaluate. I have hypertension and unexplained hypokalemia, or I have paroxysmal hypertension associated with spells, or I have Cushingoid features and hypertension. That would prompt you to look for secondary hypertension. Or if you have an adrenal incidentaloma in a patient with hypertension, that would be a reason to look for certain forms of secondary hypertension. So that brings us to case 2, which is a 37-year-old white female who's referred to you for resistant hypertension. She's complaining of fatigue and muscle cramps and occasional headaches. Her blood pressure is 170 over 100. Her BMI is slightly elevated, but her exam is otherwise unremarkable. She's taking enalapril, hydrochlorothiazide, triamterene, and atenolol. Her potassium is 2.6, and her other labs are normal. So which of the following would most likely, establish the correct diagnosis? Sending fractionated plasma metanephrines, doing a renal angiogram, measuring the aldorenin ratio, doing a low-dose dexamethasone suppression test, do a 24-hour urine aldosterone after oral sodium loading, or measure a TSH. Okay, 2 most common answers are C and E, which have to do with primary aldosteronism, and this is a case of primary aldosteronism, woman with resistant hypertension and unexplained and hypokalemia. Primary aldosteronism is one of the most common forms of secondary hypertension. Its true prevalence is not exactly known. In all hypertensive patients, primary aldosteronism is thought in various series prevalence ranges from 5 to 13%, much higher in resistant hypertension, lower in patients with hypertension and incidentaloma. So these all come from referred populations, so we're not exactly sure about these prevalence estimates. And the other problem with defining the prevalence of primary aldosteronism is the lack of a widely accepted gold standard in the way that this disease is diagnosed in these various population studies. So the Endocrine Society gives us guidelines on how to evaluate patients who we think have primary aldosteronism. So the first step, if you think someone might have primary aldosteronism, they say to perform an aldo-renin ratio. And if that's positive, then then you have a patient who probably has primary aldosteronism. And then you apply one of 4 confirmatory tests, which then confirm a diagnosis of primary aldosteronism rather than going primarily based on the aldo-renin ratio. However, there are a variety of problems with the aldo-renin ratio. First of all, looking at the Endocrine Society guidelines, there's a specific way in which it should be measured, not always convenient in the real world, in a real-world setting. There's also problems with what is a positive versus a negative aldo-renin ratio, and various studies will say various things. The Endocrine Society doesn't give us any specific guidance on what ratio should be used, and also there are varying opinions on whether the absolute plasma aldosterone concentration should be used in the diagnosis or whether you just go by the ratio. Another problem is that the ratio will be affected by a variety of different things. For example, beta blockers will suppress PRA, and this can lead to a false positive. There are a variety of other medications used to treat blood pressure or conditions which can lead in various directions to a false negative or a false positive result of the aldo-renin ratio. So this comes up because in this patient and in patients who are presenting with resistant hypertension, they're being treated with a lot of medications. And so what the Endocrine Society suggests is that you take your patient off of medications for 4 weeks before measuring the aldo-renin ratio. Or the other option is to switch them to verapamil, hydralazine, and alpha blockers for 4 weeks and then measure the aldo-renin ratio because these drugs have less effect on the ratio. So if you're going to measure the ratio and interpret it in your patient with resistant hypertension, you do one of these 2 things, which may not always be what you want to do and doesn't necessarily make sense in your patient. There are other problems with the aldo-renin ratio. First of all, it's denominator dependent. So you have a patient who's taking a beta blocker, and that's going to suppress their PRA. And regardless of what the absolute concentration of aldosterone is in the blood, you could have a high ratio simply because they're on a drug that's suppressing the PRA. And so, most assays are using a very sensitive PRA, but just a few examples depending on the PRA assay that your lab is using. If you have a patient with primary aldosteronism, is taking no medications and has a high aldosterone level, but the lab is using an insensitive PRA assay, you may get a ratio that's low, and this is a false negative result. On the other hand, if you have a patient who has a normal aldosterone level of 6, but they're taking a beta blocker, and you're using a sensitive PRA assay, and it's suppressed because they're on a beta blocker, you get a positive ratio. So the endocrine department at the Brigham is using as most of you are, has a sensitive PRA assay. They're using cutoff, when they do use this test, a ratio of 25, but also an aldo that's greater than 8. But oftentimes what is done is that if you really are suspicious that your patient has primary aldosteronism, rather than do the medicine washout for 4 weeks or change their medication for 4 weeks, to measure a ratio which will then tell you to go do a confirmatory test, is to just skip over the ratio and do the confirmatory test. And so if you're going to do a confirmatory test, you have 4 options. The outpatient oral sodium loading on the outpatient side with collection of a 24-hour urine, saline infusion, fludrocortisone stimulation, or captopril challenge. Most of the time at the Brigham, it's a 3-day oral sodium load with a 24-hour urine collection. Saline infusion requires that they spend time in an infusion center. Fludrocortisone usually requires a hospital stay. So the answer here, and I capitalize the word establish, plasma renin, the ratio of aldosterone to PRA is not incorrect, that's part of the evaluation of a patient who you think has primary aldo, but it does not establish the diagnosis, and that's not where you stop. You stop in the diagnosis of primary aldo after you do the confirmatory test. So how is this done at our hospital? Patients are given 12 packets of dry bouillon. These bouillon packets will have, about 200 or more, 50 or more millimoles of sodium. And if you then take 4 of them a day, that will be at least 200 millimoles of sodium added on to whatever sodium that they're eating in their food. So you're really sodium loading these patients. So they can pick these up at the store, or you just keep them in your clinic and you hand them out. And then on day 0, you want to make sure that you measure the potassium and their blood pressure, intensify their regimen, supplement their potassium if needed, because as you sodium load somebody with primary aldosteronism, as you know, the potassium is going to go down, blood pressure is going to go up potentially. So on day 1, you sodium load them. Day 2, you sodium load them, bring them back, have their blood pressure checked, measure their potassium, make sure you're not inducing severe hypokalemia. On day 3, again, sodium load, but collect a 24-hour urine, which you're going to measure for creatinine to make sure that it's an adequate collection, aldosterone and sodium. And if the sodium is, if it's an adequate collection and the sodium is above 200 and the aldosterone in the 24-hour urine is greater, and cutoffs differ depending on which study you're looking at, cutoffs are greater than 12 to 14 in 24 hours, then you've confirmed your diagnosis of primary aldosteronism. So you do this, and she returns her 24-hour urine, and she's got 1.2 grams of creatinine, 280 millimoles of sodium, and 54 micrograms of aldosterone. So you've just diagnosed her with primary aldosteronism. So what are you going to do now? Are you going to order an adrenal CT scan? Are you going to refer her for adrenal vein sampling? Or are you going to start spironolactone? Is there another? Nope. Okay. 58% said order an adrenal CT scan, and that is what is suggested. So for a couple of reasons. One is to rule out carcinoma. It's very uncommon to have carcinoma present as adrenal carcinoma present as primary aldosteronism. There's only, in this 50-year period, there were only 26 cases of primary aldosteronism as the presentation of adrenal carcinoma, but the CT scan will pick up adrenal carcinoma in these patients. Some authorities suggest that you can treat your patient primarily based on the CT results if they're young. So in a patient less than 35 years of age who has primary aldosteronism, and you do a CT and find a unilateral adrenaloma, that you can then proceed with definitive therapy in this patient. But not all authorities agree with this. So the answer here is order an adrenal CT scan. So in this particular patient, the CT scan reveals a 1 centimeter adenoma in the left adrenal. The right adrenal gland appears normal. So what are you going to do now? Your options are send her for resection of the left adrenal gland, refer for adrenal vein sampling, start spironolactone, or ask her if she would consider having an operation to treat her hypertension. Okay. So none of you picked refer for surgical resection of left adrenal, which is good. The point of this is to highlight that if this patient does not want to have surgery to treat her adrenal gland, that's okay. All right. There are studies, and I believe Dr. Pohl, this is his study, showed that in patients with primary aldosteronism who undergo adrenalectomy or who receive spironolactone, after a long period of follow-up, have equal control of their blood pressure and equal cardiovascular outcomes. Obviously, this is an observational study, not a randomized trial, but the suggestion here is that it is okay in your patient who does not want to have an operation to take spironolactone and to use that as treatment of the primary aldosteronism. So this particular patient would like to pursue surgery. So what do you do now? Are you going to take out the left adrenal gland or refer her for adrenal vein sampling? I guess there's a third option. Okay, good. So there was a study, a meta-analysis, systematic review, I should say, of 38 studies and about 1,000 patients with primary aldosteronism. And the question that the investigators here were asking is, if you went purely by the imaging, what would be the result in your patient with primary aldosteronism. So all the patients had an imaging study and all had adrenal vein sampling to determine whether the disease was unilateral, whether it was bilateral, and whether, and whether the adrenal vein sampling, if it was unilateral, corresponded to the imaging. And what this study found, so they asked this question: if you did a surgery on somebody who had a unilateral adenoma by imaging, or if you didn't do surgery in somebody who either you didn't see an adenoma or you saw bilateral adenomas, would surgery be appropriate or inappropriate? And what they found is that about 20% of the time, you would exclude somebody from having surgery purely based on what the imaging showed. So so these are patients who have unilateral disease, but the imaging either shows that they have bilateral disease or that there is no adenoma, even though there is a microadenoma producing aldosterone that cannot be seen by imaging. And you would do an inappropriate adrenalectomy about 20% of the time if you just went based on imaging, either because there was bilateral disease but you only saw a unilateral adenoma, or because there was an adenoma on the other side that you didn't see and you took out the wrong adrenal gland where the adenoma was. So adrenal vein sampling would be appropriate in this woman. So adrenal vein sampling confirmed unilateral disease on the left. She had a laparoscopic left adrenalectomy, and then her blood pressure was well controlled with monotherapy, 10 milligrams of lisinopril. So if you have possible patient with primary aldosteronism, you can apply a screening test or you can skip the screening test. Once you confirm primary aldosteronism, look for an adrenal CT scan. Again, some authorities, young patient, 30-year-old with a unilateral adenoma, suggest you can go right to surgery. Adrenal CT will also detect a cancer. And if they don't want to have surgery, then you can treat with spironolactone. If they want to have surgery, then you do an adrenal vein sampling to determine whether they have bilateral disease or unilateral disease. All right. So you are referred a 71-year-old woman for resistant hypertension, and she has spells consisting of headaches, palpitations, diaphoresis, and tremors. She takes acetaminophen for chronic pain and also takes amitriptyline. She's otherwise asymptomatic. Her blood pressure is 180 over 65. Her pulse is 78. Otherwise, she's unremarkable. She's taking 3 medications, irbesartan, amlodipine, and atenolol. Her PCP performed a CT scan of the abdomen and fractionated plasma metanephrines because of her spells. And the CT scan was totally normal. And the fractionated metanephrines found that the plasma norepinephrine was elevated at 1.2, which was a mild elevation over the normal of less than 0.9. The plasma metanephrine was normal. So which of the following statements is true? She probably has pheochromocytoma. It is common for patients with pheochromocytoma with spells to have normal appearing adrenal glands. C, it is common for patients with pheochromocytoma with spells to have mild elevations of fractionated plasma metanephrines. Or D, the elevated plasma norepinephrine was probably a false positive. Okay, so wide variety of answers. So just wanted to talk about some take-home points in terms of pheochromocytoma. And the first take-home point is that pheochromocytoma is a rare disorder. If you look at general hypertension populations, the prevalence is thought to be about 0.04%. In patients who have hypertension and spells, the prevalence of pheochromocytoma is about 0.4%. So it's a rare disorder. Another take-home point about pheochromocytoma is that they are typically in the adrenal gland, and typically they're easy to see with imaging. So about 90% are in the adrenal gland, and they have a characteristic appearance by CT or by MRI. And they're typically large, 3 centimeters, 4 centimeters. So the idea here is that if you have a hypertensive patient who's symptomatic with spells and you do a CT scan and you don't see a pheochromocytoma, it's very unlikely that your patient has a pheochromocytoma. The other point here is that if your radiologist calls you because you ordered a CT scan for some other reason and tells you that your patient has a pheochromocytoma, your patient has a pheochromocytoma, even if they're not hypertensive. Because pheochromocytomas can have a pre-biochemical phase where they are there in the adrenal gland but are not producing hormones and causing hypertension, not producing enough to cause hypertension. So, first of all, it's a rare disorder. Second of all, if your adrenal CT if your abdominal CT is normal, your patient is very unlikely to have a pheochromocytoma, even if they have spells. So, another take-home point about pheochromocytoma is that you should be wary of false positive results. So, most of the time, most experts will send fractionated plasma metanephrines as a first test because they're very sensitive. Although they do have a 15% false positive rate, some experts will send urine studies as their primary test. So because this is an uncommon disease and because of the false positive rate, most patients who have a positive test for plasma metanephrines will actually not have pheochromocytoma. Most of them will have a false positive test because the disease is so rare. So the other thing is, if you have a patient who really does have pheo and is symptomatic from pheo, these levels should not be mildly elevated. They should be very elevated, up to 5 times the upper limit of normal. So if they are just a tiny bit positive in your patient with spells and paroxysmal hypertension or hypertension, then it's probably a false positive. And there are a number of things which can induce a false positive result for plasma metanephrines, including tricyclic antidepressants, as well as other medications. So the answer here is that the elevated plasma norepinephrine was probably a false positive. So I put this at the end called the lightning round, and this is going to be a review of the first talk. So this is just a series of questions and answers. So you are confronted by a seemingly well 45-year-old woman who's presenting for the very first time after avoiding medical care for a long period of time. Her blood pressure in your office measured once is 151/96, and both of her parents had high blood pressure. You should, A, get more data with home monitoring or 24-hour ambulatory blood pressures, or bring her back into the office, or start antihypertensive therapy. Good. Gather more data. All right. So you set her up with an ambulatory monitor, and her average 24-hour blood pressure is 147/91. All of her labs are normal. You should, A, go over lifestyle modifications, including weight reduction, diet, alcohol, physical activity, etc., and your goal blood pressure is less than 140/90. B, you should do all of these things and your goal blood pressure is less than 130/80. C, you should start antihypertensive therapy with a goal blood pressure of less than 140/90. Or B, start antihypertensive therapy with a goal blood pressure of less than 130/80. Okay. A, lifestyle modification less than 140/90. Good. And again, she doesn't have any comorbidities other than hypertension. So after eating a healthier diet, exercising more, and losing 10 pounds, she achieves her goal. However, her blood pressure is gradually increasing at home, and she's here to see you 2 years later, and her blood pressure is 150/90, and this is consistent with what she's getting at home. And she's maintained her healthy lifestyle. She hasn't fallen off the wagon. You should, A, start atenolol, B, start hydrochlorothiazide, C, start chlorthalidone, or D, start minoxidil. I didn't put some of the other options on this list for obvious reasons. Good. Chlorthalidone. All right. So, same situation, but more options. Start atenolol, start lisinopril, start chlorthalidone, start amlodipine, or E, start either lisinopril or amlodipine. Okay. So E, start either lisinopril or a long-acting calcium channel blocker, right? Either of these are acceptable first antihypertensive drugs in patients with hypertension, and both are part of the optimal combination therapy of an ACE and a long-acting calcium channel blocker. So lisinopril would not be wrong. Lisinopril or amlodipine would not be wrong. Board questions will not be phrased in this way. C is also a very interesting option. Remember I said you wouldn't want to start with hydrochlorothiazide. Chlorthalidone as monotherapy compared with amlodipine and lisinopril had equivalent outcomes in all HAT, and as I told you, chlorthalidone is more effective as an antihypertensive agent than hydrochlorothiazide. And there have been no studies comparing dual, combination therapy. So the ACCOMPLISH trial compared hydrochlorothiazide, benazepril, with benazepril amlodipine. Okay, the diuretic ACE inhibitor arm was not chlorthalidone, benazepril. So we don't know if you compared optimal thiazide diuretic ACE inhibitor with calcium channel blocker ACE inhibitor, what those results will be. We just know that the combination therapy that included hydrochlorothiazide was not as good as the combination therapy that included amlodipine. But here, if you look at JNC, the diuretic, ACE inhibitor, ARB, or long-acting calcium channel blocker are all acceptable therapies. The nuance is, though, once you get to dual therapy, combination therapy, that your optimal combination is a calcium channel blocker with a RAS inhibitor. So sort of for ease of getting to that optimal combination therapy, starting with either lisinopril or amlodipine is the right answer here. Okay, so same patient, different scenario. So she loses 10 pounds, she eats a healthy diet, she achieves her blood pressure. She's then lost to follow-up for 5 years. And she schedules a visit with you, states her home blood pressure has risen gradually despite lifestyle, and now she is at 167/105. So now she has stage 2 hypertension, she has an S4, labs are normal. You should do which of the following? Lisinopril monotherapy, chlorthalidone monotherapy, start combination with chlorthalidone and lisinopril, or start combination therapy with amlodipine and lisinopril. Very similar to the question we just had. Right. So since there's no trial, we do not know whether amlodipine lisinopril is better than chlorthalidone and lisinopril. But based on the results of the ACCOMPLISH trial, many experts, if in patients who require dual therapy for their hypertension, will treat with an ACE inhibitor and a long-acting calcium channel blocker. Okay, so that's it. Thank you very much for coming here. Good morning.